Hi guys, good evening, good evening, good evening. Can you all see me? Can you all hear me? Can we start? Can we start? Can we start? So I'll be doing a quick recap of all the PYQs which are there for last 5 years. Hi guys, good evening, good evening. Right, so we'll try to keep it to the point. I'll not take extensive amount of time. We'll try to keep it to the point. Let's see if you're able to answer the questions that are thrown across you. Most of them will be, like you would have heard them before, nothing new, nothing out of the box. We'll try to stick to the plan. Good evening, guys. Good evening. Right. So the question number one. In question number one second, guys. Backhand team. Okay. The question number one that you have, I have a patient with a long-standing non-pitting edema which is present in the leg. What is the most probable cause? Okay. So talking about a non-pitting edema, so first let's quickly look at what are the components that is available for us. Okay. Now lymphedema, when it occurs, especially if you have chronic lymphedemas, they'll present to you as non-pitting. Correct. This is one example. Arterial one will be pitting edemas. Coronary artery is also going to be pitting edema. Whereas when you talk about the venous disorders, in the venous disorders, I can talk about two components. One is going to be your varicose veins. One is going to be your varicose veins. Another one is going to be deep vein thrombosis. Varicose veins, initially when it causes edema, that is going to be because of lymphatic blockage. Here it is going to be in the form of pitting edema. DVT will have a non-pitting edema. Will have non-pitting edema, right? So now the question is, which are the following patient with a long-standing pitting edema in the leg? What is most probable? Now, out of DVT and lymphedema, which is more common, as all of you have given your right answer, here it is going to be A for Ahmedabad. Okay. So precisely looking at the options, how do you come to a conclusive one? Okay. So this is with respect to lymphedema. Now, going on to the second question, I have a 50-year-old male patient who is a chronic smoker, okay. Presence to the hospital with intermittent claudication. I have my Q point here. The pain is present in both the thighs and the buttocks region on walking about 500 meters. What is the likely diagnosis? So, he's basically asking you, based upon the level of occlusion, can you predict? We can very well predict it, right? For example, if this is the aorta, this is the ioto-iliac junction, this is a common iliac, this is the internal iliac, this happens to be the external iliac, correct? Now I'm going to tell you, based upon the level of occlusion, where will the patient have pain that is going to be present, right? So I can say that three levels of occlusion that we'll talk about. Number one is at the ioto-iliac occlusion. Number two, it is going to be your iliac occlusion. And the last one that we're going to talk about is going to be your femoropopliteal occlusion, which is going to be here. So I've written three different sites of occlusion, which is here. Now, if a patient is having an ioto-iliac occlusion, this is what we call it as the ioto-iliac occlusion. In the ioto-iliac occlusion, the blood flow to both the vessels are going to be decreased. So hence it will have a bilateral intermittent claudication. Now obviously it is going to be not allowing the blood to flow below this point. So here it will involve the gluteus muscle. It will involve the thigh muscle. It is going to involve the gluteus muscle. It is going to involve the thigh muscles. And this is also going to involve the calf muscles. Okay? So if the level of occlusion is going to be at the ioto-iliac, correct? If there is going to be an iliac occlusion, if there is going to be an iliac occlusion, it will be associated with unilateral intermittent claudication. There will be gluteal sparing. So here it is going to be the thigh and the calf intermittent claudication. It will be thigh and calf, gluteal sparing is there. If it is going to be femoropopliteal, this is your femoropopliteal occlusion. It is a femoropopliteal occlusion. If there is a femoropopliteal occlusion, it will have a unilateral intermittent claudication involving only the calf muscle, right? Now I have the answer to my question. If the patient is having a bilateral intermittent claudication involving gluteus and thigh, the answer is going to be 𝐼𝐿IAC occlusion. Okay. So in this context, here the patient is presented with intermittent claudication in both the thighs. So here bilateral thighs are involved and bilateral gluteus muscle, that is buttocks, are involved. So what is the site? The arterial disease involving the superficial femoral, no. The arterial disease involving the 𝐼𝐿IAC looks the most likely answer. It is not venous insufficiency. It is not profunda femoris. So answer here, as rightly said, is B for Bombay. Correct. PAD, what should be considered? There won't be ABPI index. Okay. Right. So it is always to the stump site to the brachial artery. Layerich syndrome is seen in bilateral, as somebody is asking, so where do you see Layerich syndrome? Remember, if the patient is male, in male patients, the internal iliacs are going to supply to the gonads. The blood supply to the internal iliacs are going to be sacrificed. So here it is, in males, there will be bilateral intermittent claudication with male impotency. This is what we call it as the Layerich syndrome. This is what we call it as the Layerich syndrome. Correct? So this is specific for that of our male patients. Okay, answer here is B for Bombay. Going to the next question. I have a 50-year-old male patient. His routine annual checkup, he has come, found to have an abdominal aortic aneurysm measuring 40 millimeters in diameter. Okay, on ultrasound. Which of the following is true about the management of this patient? Now here, is the patient symptomatic or asymptomatic? The question says it is asymptomatic. So for management of abdominal aortic aneurysm, what is the algorithm that we follow? Now in a management of abdominal aortic aneurysm, okay, the first question is whether the patient is symptomatic or asymptomatic. Whether the patient is symptomatic or whether the patient is asymptomatic. Now, if the patient is symptomatic, irrespective of the size of the aneurysm, I am going to advise for repair. This is what we've been telling you. In an asymptomatic, I would look for something called as the critical diameter of the aneurysm. Now, the critical diameter of the abdominal aortic aneurysm is 5.5 centimeters. So, we will see whatever the aneurysm is presented is the sacs diameter. If the aneurysm sacs diameter is less than critical diameter, or if the aneurysmal sacs diameter is more than that of critical diameter. Correct. Now, if the diameter of the sac which is present is less than the critical diameter, then it is going to be observation and follow-up. This is going to be observation and follow-up. On the other hand, if the diameter of sac is more than the critical diameter, then you have to go ahead with repair, right? In the observation and follow-up, you have to see what is the presenting diameter also, right? If it is less than 4 centimeters or more than 4 centimeters, less than 4 centimeters, you'll ask the patient to follow up in 6 months. More than 4 centimeters, you'll ask to follow up in less than 4 centimeters, 1 year. More than 4 centimeters, you follow up in 6 months. Okay? Correct. But a 5.5 centimeters is the critical diameter. Do not goof up on that. Now here it says, which of the following is true about this? Do we require an urgent endovascular aneurysm repair? It is asymptomatic, 4 centimeters, that means less than 5.5, it is not in the critical diameter. Surgery is indicated if the aneurysm diameter is more than 55, it is correct. Urgent, wheel the patient to OT, no requirement. Surgery is indicated only no, it is 55, that is 5.5. Answer here is B for Bombay. Is that clear? Is that clear? Yes, a male female 5 millimeters is the component that you can vary out, but if they have not mentioned in that context of it, you can take it for 5.5 centimeters, a single important data. Clear? So, going to the next question, I have a 70-year-old female presents with pain in the thigh during walking. Investigation reveals the finding given below. Which of the following is the best surgical management for this. Okay. Now, if you look at this, I think you are very well able to identify this is the aorta, these are the iliacs, that is going to be common iliac. From here it will go to internal and external iliac. So here it is the iliac occlusion that you're going to see. Okay. Now as you can see, there is no flow here. The iliac flow is not there. It's an iliac occlusion. So aortofemoral bypass. Aortofemoral bypass would be the best one in this particular scenario. So the patient is 70 years old. The patient is going to be 70 years old. The investigation is here. So based upon the occlusion, where do we do the bypass? I'll quickly show you the bypasses also. Now imagine if this is the aorta that you have. Based upon the site of occlusion, you will decide that where do you need to do the bypass. So let's say these are the sites. These are the internal iliac. This is the external iliac. Then into common femoral and then to the popliteal artery. Okay, let's say this is the given component that you have. Now, based upon the site of occlusion, let's say if the site of occlusion is here, that is at the aortoiliac. For an aortoiliac, the bypass will be aortobifemoral bypass. This will be your aortobifemoral. It is an aortobifemoral bypass. Okay. Now, if the occlusion is found to be at this particular site, that is at the iliac one, then it is going to be an aortofemoral bypass. See? If it is here, then it is going to be your aorto. It is an aortofemoral bypass. If it is present at the femoral artery, then it is going to be an iliopopliteal bypass. This is going to be your iliopopliteal bypass. This is going to be an iliopopliteal bypass. Okay. So these are the sites of bypasses that you're going to create. If at all they want to ask in the exam, they'll ask you what is the material used for these two bypasses. We will use Dacrin. And if it comes to iliopopliteal bypass, what is the material that you're going to use? You're going to use an autologous great cephneous vein. Your autologous great cephneous vein, or you can use a polytetrafluoroethylene graft. PTFE, that is your polytetrafluoroethylene graft, can be used. Okay. So here, because we're talking about the iliac occlusion, I would go with aortofemoral bypass. So aortofemoral bypass is present as option number C. Okay. Iliofemoral नहीं करोगे यार, aortofemoral करोगे. It is an aortofemoral. If the occlusion is present at the aortoiliac, I will do an aortobifemoral bypass. If occlusion is present only in the iliac, then do aortofemoral bypass. If it is present femoral artery, then do an iliopopliteal bypass. Okay? Clear? So this is based upon the level of occlusion. You have to decide it. This has been a repeat exam question. You cannot go to the exam without knowing your bypasses. Okay? So atherosclerosis mein bypasses plays a very important role. Is that clear? Sorted? Okay, chalo. Moving on to the next one. I have a young man presented to the outpatient department with dilated veins on the left leg. According to the CEP classification of varicose vein, what will be the C stage of this patient? Now you can see the image which is very well given to you. You can see there are dilated veins which are present here. Okay, you can see the dilated veins which are present here. Not very evident per se. Okay. Now, if you look at the entire context of it, right, we'll try to understand the C classification. I hope everybody knows it. Okay. A quick recap of the C classification on the status of this. C0 indicates there is no evidence of venous disease. C1, there is telangiectasia. There is telangiectasia or reticular vein. Okay. Telangiectasia is thin thread-like veins where it is less than 1 millimeter in diameter. There will be less than 1 millimeter in diameter. Reticular vein is going to be 1 to 3 millimeters in diameter. If it becomes greater than that, it will be called as C2. C2 is nothing but your varicose vein. Varicose vein, if it is more than 3 millimeters in diameter. C3, there will be presence of edema around the ankle. C4A, there will be presence of pigmentation. C4B, it will be lipodermatosclerosis. It is lipodermatosclerosis. C4C is your coronophlebectatica. It is your coronophlebectatica. C5 is your healed venous ulcer. It is your healed venous ulcer. C6 is going to be your active venous ulcer. It is going to be an active venous ulcer. Okay. Now the question is, if you see in this, right, if you are able to see these indicated veins, see these thin thread-like veins are going to be telling ectasia slightly more bigger is reticular, but such an evident vein is going to be a varicose vein. Okay. So I know it is going to be your varicose vein. So if it is a varicose vein, you have to see whether it is C2A or C2S. Okay. Now it is the anatomical location. What is C2A? What is C2S? See, it cannot be C1 because C1 is telling ectasia reticular vein. C4A is going to be pigmentation. I cannot see pigmentation anyhow. Okay. Pigmentation is usually seen around the level of ankle. Clear? Now my question to you is it C2A or is it C2S? Is it C2A or C2S? Quick feedback. Quick feedback. Wait, I am accessing chat box. Okay. Very good. C2A is asymptomatic and C2S is symptomatic. Okay. So when we say C2A, C2A is varicose vein, which is asymptomatic. And C2S where it is symptomatic. Now why this becomes important is there's something called as C2R also. C2R basically means recurrent varicose vein. This indicates recurrent varicose vein. And there's something called as C6R, that is your recurrent venous ulcer. This is your recurrent venous ulcers. Do not forget about these. Okay. Okay. Now here the patient is presented to you with outpatient with dilated veins on the left. There is no pain, no other symptoms. It is just the dilated veins. Okay. So in that context, will you call it a symptomatic or asymptomatic? Patient is presented with dilated veins on the leg. There is no complaints of pain. There is no complaint of anything. It is asymptomatic or symptomatic. This is where the basic component lies across. So this is asymptomatic. Dilated veins does not count as symptoms. They're just a finding. Correct. Absolutely correct. Answer is going to be A for Ahmedabad. Yeah. So SEEP classification is very, very important. This should be on the tips of your finger. They can ask you what causes pigmentation. In varicose vein, what causes pigmentation? The pigmentation is because of lipodermatosclerosis. Sorry, pigmentation occurs and causes lipodermatosclerosis, but pigmentation is because of hemosiderosis. What is hemosiderosis? Pigmentation is basically because of hemosiderosis. It is because of hemosiderosis. What is hemosiderosis? It is hemosiderin plus melanin of the skin. Hemosiderosis is nothing but hemosiderin with melanin of the skin is what we call it as pigmentation. Absolutely correct. Okay. Going on to the next question. What do you have? The next question which is going to be present. Okay. A construction worker came to the OPD complaining about white fingers, has been working in cement and concrete industry, has been working on heavy machinery, drills, woods and furnishing polish for 20 years. Which is the most likely etiology of this condition? What do you think it is? Is it because of the candidal infection of the finger, exposure to the water, exposure to the thinners and the paints? Is it continuous exposure to the cements or the concretes or exposure to drills and machines? So here the patient is in the context. So is OPD complaining about white fingers, which has been working in cement and concrete. Okay, heavy machinery is there. What is the most likely condition? Quick feedback. Quick feedback. Absolutely correct. It is because of vibrations. That is continuous drills and machinery. Okay. Now this is something, this is an anticipated exam question. So you have a male patient presented with impotency, bilateral resting pain. The finding in the legs are seen as below. What is the level of the pathology that is occurred? Okay. So when you say male impotency, okay, bilateral pain, as we have already spoken about it, this is what we call it as the Leydig syndrome. And the Leydig syndrome is seen at the 𝐼𝐂-iliac bifurcation. It is at the 𝐼𝐂-iliac bifurcation. We have already seen across it. Okay. Going on to the next one. A patient presented with sudden onset of right leg pain. Investigation was done. Image was obtained in the shown below. What is this image that you can see? See, it is not a DSA because you will have an imaging prospect. It does not look like an MR, not a plethysmography. It is an USG Doppler. It is going to be your ultrasound Doppler. Okay. Chalo. Next question, which of the following is the most likely to be seen during a rupture of saccular aneurysm? Okay. So when there is an aneurysm that is going to burst, it is the aneurysm that is going to rupture in, see the options, look at the options that you have. The options that you have is SDH, that is subdural hemorrhage, SAH, subarachnoid, intracerebral and hydrocephalus. Okay. So where do you have the circle of Willis? It is in the subarachnoid space. So when it ruptures, it will cause subarachnoid hemorrhage. So answer here is going to be B for Bombay. The question that they'll ask you is, in the context of Berry's aneurysm, what is the earliest sign of ruptured Berry's aneurysm? The earliest sign of the ruptured Berry's aneurysm is going to be nuchal rigidity. Okay. They'll ask you what is the most specific sign or the most characteristic. It is your thunderclap headache. Do not forget about it. Okay. They'll also ask you, Berry's aneurysm is associated with renal disorder. In surgical component, it is polycystic kidney disease. Remember, in PKD, every patient will have or most likely to have a Berry's aneurysm. Okay? Chalo. Now, let's go to the next question. We have a patient is diagnosed with Stanford B aortic dissection. What is the most appropriate initial management of this step? So, usually when we talk about the aortic dissections, we have the 𝐷𝐵-Keys classification. Following the 𝐷𝐵-Keys classification, we have the Stanford one. Okay? So, I'll quickly talk about the aortic dissection classification so that we'll understand better. So, in the context of aortic dissection, based upon the level of dissection and the extent, we have the following components. So, if you take this as a representation of the aorta, and this is the aortic bifurcation. Okay. Now, what we have to do is, we have to see that from where does the dissection start and where does it end. Okay. So, you have something called as 𝐷𝐵-Keys type 1, so D1, that is 𝐷𝐵-Keys type 1, that is 𝐷𝐵-Keys type 2 and 𝐷𝐵-Keys type 3. So, in 𝐷𝐵-Keys type 1, the dissection starts at the level of the ascending thoracic aorta. It goes all the way to the aortic bifurcation. Okay. In 𝐷𝐵-Keys type 2, it starts at the ascending aorta, stays at the level of ascending aorta. 𝐷𝐵-Keys type 3, it descends at the descending thoracic aorta, extend all the way to the aortic bifurcation. Stanford said that I'm not going to take into consideration of the site and level, I'll only take at the site of dissection. So these two will become Stanford A. This will become Stanford A and this will become Stanford B. This will become Stanford B. Okay. Now the question that they're asking you, so we'll talk about the management also. Now in the context of the initial presentation, see in aortic dissections, you need to be extremely careful about what are you dealing with and which level are you dealing with. If they ask you, what is the most common site for the aortic dissection? I'll write just the important points. The most common site for the aortic dissection. The most common site for aortic dissection. Any takers? If you're writing your NEET PG exam, this is like a piece of cake for you. What is the most common site for aortic dissection? Quick feedback. Thank you, Nagesh. Most common site for aortic dissection. It is the right lateral wall of the ascending thoracic aorta. It is the right lateral wall of ascending thoracic aorta. It is the right lateral wall of the ascending thoracic aorta. Clear? So this is the overall most common site for this, right? Now for Stanford A, that is DBK's type 1 and type 2, it is always referred for surgery. That is going to be saccharin graft repair. For DBK's, that is type 3 or Stanford B, we are going to see whether the patient is going to be stable or unstable. So initially you're going to put it on conservative management. That is going to be monitor. If patient is unstable, then take the patient for surgery. That is your saccharin graft repair. Okay. So this is the protocol that we usually follow. Now the question is, what is the most appropriate for Stanford B? For Stanford B, if the patient is hemodynamically stable. So obviously for all patients, no, the step number 1 for both Stanford A and Stanford B is going to start the patient on cardioselective beta blockers. Okay. So the first line management here will always be a cardioselective beta blocker. Example like esmolol, right? So what we try to attain here is a permissive hypotension to decrease the pressures. That is the first and the foremost thing that you have to do here. Correct. So in all these patients, beta blocker has to be given. So administer beta blocker is correct. And intensive blood pressure monitoring, this is good. Bypass is not required, stenting is not required, dilatation is not required. So answer here for Stanford B, it is going to be conservative management monitor. That is going to be beta blocker and monitor your blood pressure. Now this was the question that was asked in NEET PG, and I hope everybody will be able to answer these. So I'm going in a systematic manner. Until this point, everybody is clear. Now you have the last one. Identify the ulcer shown in the image given below. Now this, they've asked you multiple times. If you have to see this ulcer, just put this in your head. Okay? Now when you look at this ulcer, the points that I can tell you about this is around the ankle. So I can say this is present in the gaiters area. So the first point that I can tell you that it is around the ankle. It is around the level of ankle, which is called as the gaiters area. Okay. Then you will see that this is not a very deep ulcer, it is a shallow ulcer. It has got a shallow ulcer. Then you see the edge which is there, the edge is moving inwards. So this is what we call it as sloping edge. Right. Now when you look at very carefully, even the granulation tissue is not very healthy. You can see this pale appearance of the granulation tissue. This presence of pale, scanty, unhealthy granulation tissue. This presence of pale, scanty, unhealthy, granulation tissue. The pale, scanty, unhealthy granulation tissue. And this pale, scanty, unhealthy granulation tissue, which is sloping edge, shallow ulcer around the gaiters area, is your venous ulcer. It is going to be your venous ulcer. Callus ulcers are basically chronic non-healing ulcers. These are chronic non-healing ulcers. Arterial ulcers, they are going to be deep and they will have a punched out edge. They will have a punched out edge, right? Neuropathic ulcers are going to be the same context. Okay? But then here, because the characteristic image is depicted of your venous ulcer, so I can say it is your venous ulcer. Clear? Okay? So this concludes that the image that you see here is your venous ulcer. Now, question number 41. I have a 41-year-old female presented with tortuous swelling over the left side of the scalp and the face shown in the image below. On local examination, the swelling was pulsatile and auscultation bruit was heard. Which of the following is the most likely diagnosis? It is basically a, what is this? Absolutely correct. When you have the swelling in the scalp which is pulsatile, it is your cirrhosis aneurysm. Image-based question, repeatedly asked, no need to worry about it. Okay? Moving to the next question. A patient presents to you with sudden onset of chest pain, okay, shooting onto the neck and the interscapular region. On X-ray, widening of mediastinum, BP is okay. In the right upper limb, it is 160 in the left upper. Okay, the BP is 110 on the right and 160 on the left. What is the most likely diagnosis? Differential blood pressures are there. Sudden onset of chest pain, shooting into the neck and the interscapular region. The widening of mediastinum. Why will the mediastinum widen? Because of aortic dissection. So all these are going to be in the same context. So it is not the acute coronary, it is not acute pulmonary, it is your aortic dissection. Remember, in the aortic dissection, if I have to give you a quick recap, if you take this as a representation of the heart which is present here, right? This is representing the mediastinum. This happens to be the arch of aorta that is going to go across here. Now, in the aortic dissection, if you look across here, just for the sake of understanding, your pulmonary arteries which are going to be present, or the pulmonary veins, they are going to come and open into the left atria from either sides. Okay? This is the whole scenario that you have. In an aortic dissection, you see the dissection is usually at the ascending, that is right side, right lateral wall of the ascending thoracic aorta. When this widens, this is how the aortic sac of dissection would look like. Now, this is how the aortic sac of the dissection would look like. Now, if you look at very carefully, this is the aortic shadow that you can see. Now, because the aorta is getting widened, the widening of the aorta will present to you or appear like mediastinal widening. So that is present. Okay. Now, stretching of the mediastinal pleura, because all this is covered in the mediastinal pleura that is present here. Stretching of the mediastinal pleura will cause pain in the interscapular region as well as the shoulder. Second, this dissected aneurysm, which is expanding, will exert pressure on the pulmonary veins, won't allow the blood from the lungs to come back, resulting in pulmonary edema. Okay. So there is obviously widening of mediastinum, there is pain in the interscapular region, there is pulmonary edema, all because of the same reason. So this explains. Now, obviously, there are different takeoffs here. This is going to be brachiocephalic. This is your left common carotid, left subclavian. Obviously, blood supply to the left subclavian is going to get compressed and will be more pressurized. So obviously, pressure in those vessels will be much higher. Okay. So it depends upon the differential pressure, also depends upon the sacs dissecting component. Okay. So answer here is going to be C for Calcutta. No further explanation is required. Right. So that was all the questions that was asked from your vascular disorders up till this point. Right. So far, any questions, quick feedback? Any other questions or any other topic that you want to ask me? Quick feedback. Quick feedback. So going on to the next one, trauma important. Which of the following is not a part of the primary survey? Okay. Now we have been asking this again and again and again. Primary survey mein, what is the goal? So let's determine the goal of the primary survey. The goal of the primary survey is to rule out any immediate life-threatening injury. Usually we'll try to rely on the clinical components. If it is not possible, then I will resort to the radiological investigations, which are going to be easily available, accessible with a shorter duration of time. So blood pressure monitoring is going to be very, very important, because in the circulation, what are you going to look for? You're going to look for heart rate and the systolic blood pressure are the two important parameters to determine shock. Okay. Removing cloths to inspect the wound, yes, so that I know whether there's an active bleed or present or not, so that I can press and compress it. CT will take time. I will never do that. Checking for airway patency is the first and the foremost important thing. So the other three are going to be for your primary survey. B cannot be your primary survey. Absolutely. Sorry, C cannot be your primary survey. That is, CT cannot be the answer. Absolutely correct. Okay. So going on to the next question. What do you have? I have a middle-aged man presented to the emergency department with upper abdominal pain and after having a heavy meal. On clinical examination, the upper abdominal tenderness was noted. On chest radiograph, widening of the mediastinum with pneumomediastinum was seen. Which is the probable diagnosis? You have a middle-aged man, emergency department, upper abdominal pain after having a heavy meal. On clinical examination, this tenderness was noticed. On the chest radiograph, there is widening of the mediastinum is present and the pneumomediastinum. So in order to have a pneumomediastinum, the air has to leak from somewhere. Can it be spontaneous perforation of esophagus? Yes. Perforation of peptic ulcer disease will not cause pneumomediastinum. It will cause pneumoperitoneum. So here you will have presence of pneumoperitoneum, not with pneumomediastinum. Foreign body in the esophagus cannot cause pneumomediastinum. Okay. Rupture of emphysematous bulla of the lung. Yes, the bulla of the lung can cause the pneumomediastinum, but it cannot cause abdominal pain. So this is wrong. So answer here is going to be A for Ahmedabad. Okay. Now, as we all know this is going to be, see, in Boerhaave syndrome, just to a spontaneous esophageal perforation, one of the examples that you have is going to be a Boerhaave syndrome. Okay. Now, in Boerhaave syndrome, what is the triad that you have? You have something called as the Mackler's triad. There's something called as the Mackler's triad. In the Mackler's triad, the patient is going to have retching. It is retching followed by vomiting, which is going to cause sudden severe onset of retrosternal chest pain. And along with that, there will be cervical subcutaneous emphysema. There will be cervical subcutaneous emphysema is noticed. Now, the cervical subcutaneous emphysema will also cause pneumomediastinum. In the exam, they'll ask you what is the auscultatory finding that you see in pneumomediastinum. Quick feedback. What is the auscultatory finding that you will see in pneumomediastinum? Pneumomediastinum की auscultatory finding क्या है? On auscultation. On auscultation, what do you find? You're going to find what is that called as the Hayman crunch sign. This Hayman crunch sign appears as a man walking on a snow. It appears as if man walking on snow with snow boots. It is a man walking on a snow with a snow boots on. It's called as Hayman crunch sign. Absolutely correct. Okay. So this is in this context, right? Going on to the next one. Next question. Our 30-year-old man brought to the emergency department after suffering a stab injury to the lower chest. Okay. He has bradycardia and hypotension, which does not improve despite of IV fluid administration. The chest radiograph showed clear lung fields. What is the next step in the management? Abhijit sir, in primary survey, control of local bleeding is first, or C-spine stabilization, which is to be chosen first. But whenever there is a circulatory component which has been released, always visible bleeds has to be controlled, followed by your C-spine stabilization. But if there's no visible bleeds, then always the cervical spine stabilization takes priority on that. Okay? So here, coming to this question, I have a patient who's been brought to the emergency department after a stab injury in the lower chest. He has bradycardia and hypotension, okay, which did not improve on IV fluids administration. Okay. So the chest radiographs was showing clear lung fields. What is the next step management? Is it going to be an EFAST? Is it going to be a tube thoracostomy? Is it going to be a CECT chest or the CECT abdomen? What is your likely answer? Right. See, when you have the component where the patient is having bradycardia with hypotension, okay. Now, usually in a status of shock, you'll have tachycardia with hypertension. If the lung clear fields are present, that means there is no pneumoperitoneum also. Okay. Now, this becomes slightly tricky to answer. Let's see what is your objective. Most of you are saying A, that is EFAST. Okay. Right. Now, when you talk, which is not improving on IV fluids, that means the patient is deteriorating fast. Okay. So, whenever the patient is deteriorating fast, so the first thing, for all patients, he is being present with the stab injuries. Ideally, you have to take the patient for tube thoracostomy, right? So the patient, the stab injury is there, so it could create an open pneumothorax to a tube thoracostomy because you are suspecting the component here. So answer here is going to be B for Bombay. So next you have the next question. A man was brought to the emergency department after he fell into a manhole and injured his perineum. He get urged to micturate but unable to urinate. On examination, blood was seen at the tip of the urethra and the swelling of the penis and the scrotum was seen. Which is the more... See, if the urine is collected in the scrotum and the penis, the answer is going to be your bulbar urethral injury. It is going to be your bulbar urethral injury. In the membranous urethral injury, you will have deep extravasation. So answer here is you don't need to worry about it. It's B for Bombay. See, I have already explained you in detail. When you go back to your previous videos, you will see that the Colles fascia, which is going to be in continuity with the scrotum wall as well as the anterior abdominal wall. So if the urine gets collected into the anterior abdominal wall, penis or scrotum, the answer is going to be bulbar urethral injuries. Okay? So let's look at the next question. Identify the investigation and the lesion depicted in the image given below. Okay? Achha. When you look at the whole component, this is, you are seeing the imaging in a reverse direction, which is here. So it is your retrograde urethrogram. It is not a maturating sister urethrogram. You can see it has been fenestrated here. So it is an RGU, that is your retrograde urethrogram. So first look at the options that you have. MCU wale options delete kar lo. So it cannot be your maturating sister urethrogram. So I can say that I can rule out option number C and the option number D. Gone. Now you look at the urethra per se. Okay? This is misbehaving. Okay. So when you look at the urethral component, just for the sake of understanding, if I label it, this happens to be the bladder. I don't have a problem. From this point, this is going to be your prostatic urethra. You see, there's a transition in the prostatic urethra. From here, this is going to be your membranous urethra. This is going to be your membranous urethra. Then you see there's a nice hunch that is present. This is your bulbar urethra. And the last one that you can see here, this happens to be your penile urethra. Now you can see the injury that you're treating is a stricturous component which is present at the junction of the penile and the bulbar. So usually from this pelvic brim that you can see from here, the bulbar urethra, it still belongs to the pinobulbar junction, but I'll consider as penile urethra. Okay. Now, what is the option that you have? It's a retrograde urethrogram with membranous urethral injury. Membranous to possible ही नहीं है. It has to be a tie between the bulbar and penile. When you have no other option but the penile, answer here is B for Bombay. Clear? So you now know how to attempt our retrograde urethral injury exam questions. So be very clear and careful about it. Okay? But in an MCU, you will see there is contrast flowing from the ureters into the bladder, then into the urethra. But if you see the contrast going in a retrograde fashion, then it is going to be a RG. So, moving to the next one. A patient comes to the casualty, okay, with severe headache. His BP was found to be more. CT revealed a subarachnoid hemorrhage. What is the next best step in the management? Okay. Now, he's an hypertensive, right? For a subarachnoid hemorrhage, it can be because of ruptured Perry's aneurysm. It can be because of ruptured Berry's aneurysm. Okay. The first thing, the most important risk factor is going to be for ruptured is hypertension, right? So obviously I have to control the blood pressure first. It is not the angiography or surgery, not the fibrinolytic therapy. Nifedipine, that is going to be, or nimodipine, calcium channel blocker is likely to be the best component. But angiography, he's asking next best step in the management. Right? Control the blood pressure and then go with angiography. So first is always calcium channel blocker and then move for angiography. Okay? Moving on to the next one. A patient had a road traffic accident, presented with the abdominal pain. The resident examines the child, finds out vitals are stable. Tenderness was present in the left lumbar region. What is the best investigation of choice? Okay, he's asking this question. This is easier. Come on, quick. Road traffic accident, pain abdomen, patient is stable, there's tenderness in the left lumbar region. You're thinking about renal injuries. In the component of this is the best investigation. let's rule out. I will not do a laparotomy because patient is stable. I will not wait and watch because I don't know what are you waiting for. So retrograde urethrogram is done only if there are urethral injury suspected. Lumbar component is renal component. In the renal component, I will, for any abdominal injuries, the best one is going to be CCT abdomen. Okay? इसमें ज़्यादा नाटक नहीं है. Let's not try to break your head against it. This is going to be the component that you have to remember. Chalo. Moving on to the next one. I have a patient presented to your motorcycle road traffic accident. Okay, with no reported pain or injury. Okay. During examination, blood is observed at tip of the urethral meatus. The bladder is non-palpable. What would be your next step? Road traffic accident, unable to pass urine, blood at the meatus. This is all indicative of your posterior urethral injuries. That is your membranous urethral injuries. It is going to be your membranous urethral injury. That is your posterior urethral injury. Now, if there is a posterior urethral injury or an anterior urethral injury, you will do a retrograde uretherogram. On the basis of retrograde uretherogram, you will see whether it's a partial injury or a complete injury. Whether it's a partial injury or whether it is a complete injury. If it's a complete injury, I will do a suprapubic cystostomy. Partial, I will do one attempt of Foley's catheter. If it fails, suprapubic cystostomy. This is the algorithm that we follow. ठीक है, इसमें कोई if or but नहीं है. Now I am saying a patient is having a road traffic accident, blood at the meatus, bladder non-palpable. I now know it's a membranous urethral injury, right? What would be your next step in the management? Now it is either you are going for Foley's catheterization, wait for the bladder to fill, do a nephrogram, or suprapubic cystostomy. Okay. What is your likely management? What would you like to do? Quick feedback. So I have two options which are filling up. See, everybody knows that SPC is done only if there is a complete urethral injury. To identify it's a complete urethral injury, you have to do a retrograde uretherogram. Okay? That's what beta. If there is only blood at the meatus, okay? Yeah, the confusion, I know you are confused between either to catheterize or wait till the bladder to fill. Okay? Absolutely correct, Debajit. The correct answer here is allow the bladder to fill up because of the urethral injury, and he is not telling me this partial or complete. I will not put the Foley's catheter. By that logic, you can simply say that wait for the bladder to fill. Once the bladder fills up, do a suprapubic cystostomy. Okay? That is the right answer. So the exact extension of this point would be wait for the bladder to fill and then do a suprapubic cystostomy. This, lot of students got it wrong in their previous exams also. Okay? So I hope everybody is clear at this point that how do you approach this question. Fair enough? So, moving to the next question. A patient on a road traffic accident presented with subcutaneous emphysema. On auscultation, there is no air entry in the right side. Vitals were unstable. What will be your immediate step in the management? Now, if there is a subcutaneous emphysema, there is no air entry on the right side, vitals are there, after vitals are unstable and the patient is having a road traffic accident, I am now suspecting that this patient is having right pneumothorax. Okay. Now, because it is not telling any stab injury, I am presuming it is a tension pneumothorax, right? I am presuming it is a tension pneumothorax. Now, they're asking what way in tension pneumothorax, you have to put the wide bore needle, right? Where would you put the needle? In emergency, everybody knows I am going to put the wide bore needle, that is needle thoracostomy has to be done. Here we would do something called as the needle thoracostomy. Now my question is where? If the patient is an adult, in an adult we will put in the 5th intercostal space of the mid axillary line. In a child, it is going to be the 2nd intercostal space in the mid clavicular line, right? As a definitive management, we all know we are going to put the intercostal drain, that is ICD, in the safety triangle. So here, what is the immediate management? Insert a wide bore needle in the 5th intercostal space is correct. Wide bore needle and decompression IV fluids. Intubate and positive pressure is not required. EFAST is not required here. It will be next immediate management. He's asking for management. The investigation cannot be a management. So here wide bore needle insertion in the 5th intercostal space in the mid axillary line is the right answer. Okay. Somebody saying wide bore needle decompression. Wide bore needle decompression with IV fluids. But in the option number A, they have given you precisely where to put. So that is a better option when compared to IV fluids. So here the instability, why it is unstable, can be because of pressures also. You put the needle, let it to come out, see whether it is, see, meanwhile you will also do ABCD, that is important. But if the context of the question is there, this is what you have to go across. Okay. So going to the next question, a patient brought to the emergency room following a road traffic accident. On examination, patient opens his eyes to painful stimulus, speaks inappropriately and withdraws his limbs to a painful stimulus. What is your GCS score? Now, this is like something we have been asking again and again and again, so nothing spectacular about it, right? In the eye opening, we have E4, V5 and M6, right? Motor is the most reliable one that you have. Now, in the E4 component, 4 is going to be spontaneous eye opening. 3 is going to be to the oral command. 2 is going to be with painful stimulus. 1 is going to be no response. So here the patient is opening to the painful stimulus. So I can say E is going to be 2. Verbal response 5 if he is going to is oriented to the time, place and person. Okay. 4 if the patient is confused. 3 if he is using inappropriate words. 2, it is going to be incomprehensible sounds. That means we are not able to understand what the patient is saying. 1, the patient has no response. So here the patient is having inappropriate words. Inappropriate is going to be 2 again. So verbal response is going to be, sorry, inappropriate is going to be 3. Inappropriate sounds is going to be 3. So V3 is there. In the motor response, 6 if he obeys all the commands, right? If he is obeying all the commands, it is going to be a score of 6. Okay. Now a score of 5. See, in the motor response, now when you look at the whole components, I'll give you an easy trick to remember. 1 का मतलब हो गया no response. Okay. Now you have decorticate and decerebrate rigidity. Decorticate, it is decorticate. This is decerebrate. Okay. So decorticate rigidity and decerebrate rigidity is going to be an extension and a flexion rigidity. Okay. Now once you have with this, if the patient localized to pain, 5. If he withdraws to pain, a score of 4 is given. This withdrawing to the pain, a score of 4. So M will be 4. So answer here is going to be E2, V3, M4 is going to be C for Calcutta. It is going to be C for Calcutta. Clear? See, GCS scoring is something that they'll ask you again and again and again, right? You cannot go to the exam without knowing your GCS scoring systems, right? In the GCS, only couple of important questions that they'll usually ask you is, what is GCS P score? A GCS P score is where you're considering pupillary reaction. Okay. In a pupillary reaction score, when you add, in a pupillary reaction score, so what is this pupillary reaction score? If bilateral pupil reactive to light. If bilateral pupil reactive to light, a score of 0. If only one pupil reactive to light, a score of -1. If both the pupils, unreactive or non-reactive to light, a score of -2 is given. A score of -2 is given. That is your pupillary assessment scoring system that you're going to add. Okay. Achha. Beyond this, what else can they ask you? They can ask you something called as, based upon the GCS score, what is the head injury classification? We call it as GCS head injury classification. So in this GCS head injury classification, we have the minor head injury, then you have mild, then you have moderate, and then you have severe. Mild GCS is going to be 15/15 with no loss of consciousness. GCS remains 15/15 with no loss of consciousness. Okay. On the other hand, if the GCS is going to be 14 or 15 but with loss of consciousness is mild. If the GCS is going to be 9 to 13, it is moderate. Less than or equal to 8, it will be considered as severe. Okay. Yeah. Now, another question that they can ask you is, what is the indication for intubation? Remember, a GCS of less than or equal to 8 is an indication for intubation. Now, if the patient is intubated, how will you calculate the GCS score? We say E4V cannot be calculated because it is tubed. So, it is tube. Motor response will be 6. So, this will be calculated as 10T upon 10T. T stands for intubated status. 10T indicates, or T stands for intubated status. It indicates intubated status. Okay? Clear? Yeah. So this is on the basis of GCS. GCS is going to be very important throughout our exam component. Okay, going on to the next question. I have a young patient admitted with the history of fever for 5 days. Blood pressure is low. Pulse rate is high. Respiratory rate is also high. GCS is 10. Lab test shows leukocytosis with neutrophils. Serum creatinine level is high. An intern doctor wants to calculate the SOFA score to predict the prognosis. Hospitalization. Okay, which of the following comprises of 𝐶-SOFA scoring system? Right. Now, 𝐶-SOFA, we've been, see, multiple times I've been asking about the same component again and again. So you need to understand 4 important components. Okay. So one is going to be SIRS. Following by SIRS, we will talk about the SOFA and the 𝐶-SOFA scoring system. Right. So when I say these are the terms that you have to remember it repeatedly again and again. What does SIRS stands for? SIRS is your systemic inflammatory response syndrome. SIRS stands for systemic inflammatory response syndrome. Now, in systemic inflammatory response syndrome, what are the components that you're going to consider? Now, the first one is going to be a body temperature. If a body temperature is less than 36 degrees Celsius or more than 38 degrees Celsius. Okay. Okay. Second, we are going to consider for WBC count less than 4,000 or more than 12,000. Okay. The third one that you will consider is going to be respiratory rate if it is more than 20 cycles per minute. And the last one is going to be your heart rate if it is more than 90 beats per minute. Now we say if any two is positive, we say patient is in SIRS. If any two of these parameters are positive, we say patient is in systemic inflammatory response syndrome. As simple as that. Now, based upon this, you have the following definitions, right? What is sepsis? Sepsis is considered to be systemic inflammatory response syndrome with known foci of infection. With known foci of infection. With the known foci of infection. What is septic shock? What is septic shock? It is sepsis with hypotension. With hypotension not responding. With not responding to IV fluid. It is sepsis with hypotension not responding to IV fluids. Then you have MODS, multiple organ dysfunction syndrome, when more than or equal to 2 organs fail at the same time. Fail at the same time. This is what we call it as MODS. Then you have something called as the 𝐶-SOFA scoring system. But 𝐒𝐻, we have already discussed it. If you are looking for 𝐒𝐻, I have already described the components of 𝐒𝐻. Okay. It's there on the first few questions which are discussed on the vascular disorder. You can just go look at it. Okay. Okay. Then you have something called as 𝐶-SOFA scoring. 𝐶-SOFA stands for quick. It indicates quick sequential. It is quick sequential organ failure assessment score. Organ failure assessment score is what we call it as 𝐶-SOFA. Now, what are the components of the 𝐶-SOFA scoring that you will look across here? In the 𝐶-SOFA score, we'll look at the systolic blood pressure, we'll look at the respiratory rate, and we'll look at the Glasgow Coma Scale. If the systolic blood pressure is less than 100 millimeters of mercury, if the respiratory rate is more than 20 cycles per minute, and if the GCS decreases, right, that is if the GCS is going to be less than or equal to 14, that indicates the component, right? So same thing that we have already discussed it in the component of SOFA and 𝐶-SOFA scores. So again, any two positive indicates poor prognosis. Any two positive indicates poor prognosis, that you have to remember across. Okay? Clear, guys? So in 𝐶-SOFA, respiratory rate is 22 beta. In 𝐶-SOFA, respiratory rate has to be more than 22 cycles per minute, not 20. So 22 cycles per minute. The only difference that you will see in SIRS and 𝐶-SOFA is respiratory rate. In your SIRS it is 20, in your 𝐶-SOFA it is 22. Clear? Quick feedback. Clear है? ठीक है? चलो. Correct. So coming back to this question, the following compromise of 𝐶-SOFA. What is 𝐶-SOFA? Is systolic blood pressure, respiratory rate, and GCS. ठीक है? So systolic blood pressure, respiratory, and GCS. Option here is going to be D for Delhi. Right? So far so good. Chalo. Going to the next question. According to the triage, which of the following category of the patients comes under green? But when you talk about triage, no, I think everybody knows a couple of important questions that is asked on the triage. The triage is done on the basis of the criteria for doing a triage. It is basis of the outcome when compared to severity. Now, when you look at the order in which you have to respond, the first one is red, the second one is going to be yellow, then it is going to be green, and the last one is going to be black. There is a new tag which is blue, which is going to be moribund. Okay? So I'm just going to add blue here. So rather than having black first, then we put blue and last is black. Right? Now, when you talk about all these components, this is the priority list. The highest priority is for the red, the least priority is for the black. The red basically indicates emergency, which requires immediate attention. Yellow basically is urgent. Green is a delayed component. Blue, it is going to be moribund. Black is going to be dead patient. It is going to be a dead patient. Okay. On that context, we can say according to triage, the comes under green. Ambulatory patients, yes. Medium risk, high risk, dead patient, no. All ambulatory patients will be considered as green. Okay. All ambulatory patients, no medium risk, no high risk. These patients, no. You can go sip a coffee and come back. They'll still stay alive. Don't worry about it. Okay. Clear? Quick feedback. Quick feedback. Examples for red, yellow. But we have already spoken in great detail about it. Any patients who has come with extensive blood loss or patient is hemodynamically unstable will be red. All fractures will be considered as yellow, especially open fractures. All lacerations and all will be considered as going to be your delayed presentation. Okay. Clear, guys? Can we move on? Okay, somebody is already giving me the answer. Identify the fluid shown in the below. Okay. When you talk about the HEMA-seal, that is going to be colloid. Okay. Your isolate P, isolate M all in the same context. You have ringer lactate here. So what is the composition of? See, there is no normal saline to consider one for. When you talk about normal saline, in normal saline, you have sodium and chloride. Both of them will be in equal composition of 154 milliequivalents. Okay. So this is the first thing that we expect you to know. Now, when it comes down to the Ringer lactate, obviously Ringer lactate is also called as the Hartmann's. There's a small gap in that. But if you look at it, it consists of sodium, it consists of potassium, it also consists of chloride. So if you have these three elements, they're more likely to be your Ringer lactate. Okay? They're more likely to be your Ringer lactate. So when you look at the entire composition, this goes in favor of Ringer lactate. Nobody is going to ask you the composition of HEMA-Cele, isolate P and isolate M, but they'll definitely ask you between the sodium chloride, that is your normal saline, and the Ringer lactate. This is what you're supposed to remember. Quick feedback. Good with this? Clear? I don't want to create a whole table. We have discussed it enough about the IV fluids. You can go back, see the lectures as well. Okay, the next question that we have. I have a young male patient with the history of motor vehicle accident, unable to pass urine, blood is seen at the meatus. What is the most likely site of the urethral injury that you can see here? Okay. Again, you can see this is the penile urethra. This happens to bulbar urethra. This is your membranous, and this is going to be your prostatic urethra. Okay. So here, usually when you have, see the pickup point which is present here is motor vehicle accident. Okay. In a road traffic accident, if there is a manhole injury, then it is bulbar. Otherwise, it is going to be a membranous urethral injury. So, based upon this, a young male, blood is seen at the meatus. What is the most likely diagnosis? So, if I say this happens to be your penile urethra, from here, this is going to be your bulbar urethra. From bulbar urethra, this is going to be your membranous. This is going to be prostatic. This is prostatic, this is membranous, this is bulbar, this is penile urethra. You can see here the contrast is at the level of the membranous urethra, right? So answer here is going to be C for Calcutta. Okay. So you have the next question. I have a child had a history of a stab injury to the anterior abdominal wall, and the image is shown below. The child is hemodynamically stable. What is the next course of treatment? Now, for all stab wounds, if the patient is going to be hemodynamically stable, okay, in an hemodynamically stable, if you look at the entire context of the abdominal stab injuries, any patient who has presented with an abdominal stab injury, the first thing you see, stable or unstable. We'll see whether the patient is stable or whether the patient is unstable. If the patient is unstable, take the patient for exploratory. Take the patient for exploratory laparotomy. Correct? Now, when you look here, patient is hemodynamically stable in our question. So the laparotomy is out of the context which has been put across here. Okay? Now, if the patient is stable, in a stable patient, I will see the weapon of stab is in C2 or not in C2. If the weapon of stab, if it is in C2 or not in C2. If it is in C2, I cannot do a wound exploration. I have to take for CECT abdomen. If it is not in C2, you can do a wound exploration. In a wound exploration, you will see peritoneal breach is present or not. You look for peritoneal breach. If peritoneal breach is absent or present, if it is present, do a CECT of the abdomen. If it is absent, do a wound closure. This is the simplest algorithm that you can follow for the abdominal stab injuries. Okay. Now apply this. Now the patient is stable. Okay. As you can see, the glass is still sticking out. So the weapon of stab is in C2. So I have to go with CECT. Okay. Now the option of CECT is not here. I would not, there's no point observing. Okay, there's no point of observation. So observation can also be striked out. Okay. They're saying which will be the next course of treatment. So next course of treatment obviously looks for IV fluid for all patients of, let's say, even if the patient is going to be, See, wait and watch and observation, all these are useless components. Okay. The best option that can sit across here is going to be your IV hydration, or again intravenous fluids can be administered, and then take the patient for CECT. That should be the ideal component. Okay. But a fast is for blunt trauma abdomen. Do not goof up. Do not answer as fast as the answer. You will goof up in that context. Okay. This is the algorithm that you follow for the abdominal stab injuries. Okay. So, going into the next question, what do you have? A 76 years old man, confusion. Okay. He's on antihypertensive medication, on aspirin with recent MI. Trivial fall from the chair 3 weeks ago. Neurological examination was normal. What is the most likely diagnosis? I don't even need to tell you, the diagnosis is here. You can see it is coming like this. One end is going to be concave, the other end is going to be convex. It is convex opacity. There's going to be subdural hemorrhage. C for Calcutta. Okay? It's an example of a subdural hemorrhage, convex opacity. So when we talk about subdural hemorrhage, it is because it is seen in elderly patients. It is seen after a trivial trauma. That is insignificant injury. The bleed occurs because of cortical bridging veins. It is because of injury to the cortical bridging veins. On a radiograph, it will have convex opacity. It's a convex opacity, and this convex opacity is also called as the crescent opacity, also referred to as the crescent opacity, Management for small SDH, it is conservative. For small SDH, it is conservative. For large SDH, it is going to be craniotomy. For chronic SDH, when I say chronic SDH, which is more than of 21 days, this is going to be burr hole surgery. This is going to be a burr hole surgery. Okay. Clear? So here it is going to be the subdural hemorrhage. Subarachnoid is ruptured Berry's aneurysm, where you can have periventricular bleed and all that. So not very important. Okay. So going on to the next question. Somebody's already given me the answer. Absolutely correct. You can see I have a man presented to the emergency department after a road traffic accident, complains of chest pain, breathing difficulty, X-rays given below. What type of breathing pattern do you expect in this patient? When you look at this, what do you have? I have broken rib number 1, broken rib number 2, I can see 3, I can see 4. Okay. So this is broken, this appears to be broken, this is broken. So when you have multiple rib fractures, that is more than or equal to 2 ribs at 2 different sites, is what we call it as flail chest. And in flail chest, what type of breathing do you have? Irrespective, it is going to be your paradoxical movement. That is, during inspiration, the chest wall is going to be drawn inwards rather than going outwards. Remember, the most important thing to manage in flail chest is going to be pain. Adequate analgesia is the first line of management. If the patient goes into respiratory failure, I will now present the patient with IPPV, that is intermittent positive pressure ventilation. Banding and splinting is contraindicated. Rib fixation is the new, I would say, the modality that is developing with respect to your flail chest. Okay. So that is all that you should know in the context of trauma as well. So I hope everybody is clear until this point. Koi sawal? Koi shak? Any questions? Quick feedback. Quick feedback. Can you move on? Can we move on? My chat box 1 second, let me refresh. Okay. So, the next question, which of the following is the Miami criteria for intraoperative parathyroid hormone measurement? देखो, Miami criteria is very, 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 very important. So what is the Miami criteria basically tells you is do a pre-operative parathyroid hormone level. This is what you measure. Okay. Then you remove diseased parathyroid gland. Now, this diseased parathyroid gland can be because of adenoma, hyperplasia, or in the context of any other component as well. Now, sorry, measure intraoperative parathyroid hormone levels. Measure intraoperative parathyroid hormone. When you measure, we measure at 5 minutes, we measure at 10 minutes, and we measure at 15 minutes. Okay. At 5 minutes, the parathyroid hormone level should drop. By 10 minutes, you should have seen that more than 50% of the pre-operative value should be dropped and further decrease in parathyroid hormone level should be seen. So if you look at the three criteria that we laid down at 5, 10, 15, the component where you're fixed is at 10 minutes, 50%. At the 10-minute mark, there should be more than 50% drop in its pre-operative value. Then it is considered that you have removed the right gland. Okay. So here, so it is going to be fall in half, that is 50%. At the 10-minute mark, the answer here is going to be D for Delhi. Clear? So this is your Miami's criteria to determine whether you have removed the right parathyroid gland or not. Clear? So, now going on to the next one, the GIT. So one more question that they can ask you in parathyroid component here. Usually asked is, what is the investigation of choice for primary hyperparathyroidism? What is the investigation of choice for primary hyperparathyroidism? The answer is going to be cysta. It is going to be the cysta MBBS. If they ask you what is the best or the gold standard investigation, the answer is going to be 4D CT. Same thing, they'll ask you investigation of choice for parathyroid adenoma. For the parathyroid adenoma, the answer is same, the cysta. Cysta maybe. Okay. The same thing is going to be validated again and again. Okay. Yeah. So, can we move on? Now, to go to previous questions that were asked in GIT. Okay, now I think this is more or less you can just quickly stream through as well. But for my component, I have an 80-year-old woman presented with the complaints of fatigue. On imaging, she was found to have a sclerotrophic gallbladder with impacted stone in it. Okay, a large stone was also present in the CBD, which is present, and the biliary tree is dilated. What is the next step in the management? Okay. Now you have an sclerotrophic gallbladder is nothing but a fibrotic gallbladder with impacted stone in it. Okay. The CBD stone which is present also, which is going to be here. Now, what are the options that we have? Immediately take up the patient for cholecystectomy. The elderly patient, chronic fibrotic gallbladders did not cause any problem until 80, unlikely to cause anything. So no need to do anything. CBD stone, I need to remove it or conclude with ERCP, I can do it. What will you do? Wait and watch. I don't understand. There's no role for CT here, right? So a large stone was present in a CBD and the bile duct is dilated. Do a ERCP. Release the stone and give it off. I have a 32-year-old male diagnosed with achalasia cardia. A high resolution manometry revealed a massive simultaneous high pressured contractions of the distal esophagus. According to the Chicago's classification, the patient has which type of achalasia cardia? Now, whenever we talk about achalasia cardia, we've been talking about there are two important components in achalasia cardia that we have to consider, right? Number one is something called as the IRP. What does IRP stands for? It stands for the integrated relaxation pressure. Now, in order to say the patient is now having achalasia cardia, this IRP has to be more than or equal to 15 millimeters of mercury. I need to have an integrated relaxation pressure of more than 15 millimeters of mercury. I know, see, please, I don't want you to get ahead of yourself because there are a lot of if and buts in the Chicago's classification. If you do not analyze or assess the Chicago's classification properly, we are going to goof up in many different components. I've been telling you again and again, do not take Chicago classification lightly, because when they ask a question, they can ask you from achalasia cardia or from a diffuse esophageal spasm with the same numbers and components which are going to vary. Okay. So let's just not get ahead of yourself. Guys, I know you're trying to give answers. I am pretty happy that you know the answer, but I want you to have a clear-cut component also. So please do not try to override your answers because it is going to get difficult. 1 second. Same chat box. 1 second, guys. All right. So if you're able to watch me, just give me a second. I'm re-logging in. Right. So as I told you, the first thing that you have to consider is your integrated relaxation pressure. That is going to be 15. It is going to be same for all three. That is type 1, type 2, as well as type 3 achalasia cardia. In type 1, you have 100% failed peristalsis. You have 100% failed peristalsis, right? In type 2, you will have 100% failed peristalsis with pan-esophageal pressurization. With pan-esophageal pressurization. In type 3 achalasia cardia, you will have a premature contraction. There will be premature contractions in the esophagus. There will be failed peristalsis. There will be failed peristalsis. There will be failed peristalsis with or without pan-esophageal pressurization. Okay. Now here the patient is having a massive simultaneous high pressure contraction on the distal end, right? So it's only the last component that you see, and in the last component which is going to be associated with the premature contractions which are going to be present. Okay. So this is going to be your, see, in type 1 it is going to be 100% failed peristalsis. There is no failed peristalsis being talked about. Type 2 also there has to be failed peristalsis. There is no type 4. By default the answer will become D itself. Okay. It is going to be type 3. So your pickup point is type 1 100% failed peristalsis, type 2 100% failed peristalsis with pan-esophageal pressurization, type 3 is premature contraction with failed peristalsis with or without pan-esophageal pressurization is important. Did you all get this? Quick feedback. Quick feedback. Spasm. See, if I have to put it in the form of spasm, There are different components which have been added to it. No. So don't take it as one single algorithm, beta. This is what you have to follow. Simple, easy, keep it to the point. Let's not confuse ourselves much. Can we move on? Okay. See, I can give you, if you want to know more about this entire Chicago's classification, you have an entire video which is there on the surgery BLS that is we have done on a series. It's a Bailey and Love series which is there on YouTube. We discuss every single topic that is there in Bailey and Love. I've done an exclusive video on manometry. If you want to have a quick recap on manometry, just go watch that video. Okay. Can we move on? Quick feedback. See guys, I am not able to access the chat box. That is why I'm having a little bit of issue interacting with you. But I think more or less you guys are able to. A second. I don't know. Something is wrong with my app. Yeah, let's go to the next question. Next question. So what do you have in the next question? While performing a surgery on a patient who has presented with clinical features of peritonitis, diverticular perforation is seen along with fecal peritonitis. What stage of Hinch's it is? But Hinch's, no, we have been talking about it. First of all, the question itself is where do you have Hinch's classification or the Hinch's staging? Hinch's is for diverticulitis. It is a CCT based classification for diverticulitis. It is a CCT based classification for diverticulitis. Now, what is this Hinch's classification? You have stage 0 where you have only colonic wall thickening. There is only presence of colonic wall thickening. The colonic wall thickening is what we call it stage 0. Everybody knows it. What is stage 1? Stage 1 is going to be phlegmon. Phlegmon is inflammatory fluid collection around the colon with pericolonic fat stranding. Then you have, this is basically 1A. If I have to add 1B, 1B is going to be pericolonic abscess. You have pericolonic abscess, which is going to be 1B. Then you have stage 2, which is intra-abdominal or pelvic abscess. It is intra-abdominal or pelvic abscess. It is intra-abdominal or the pelvic abscess. Stage 3 is your purulent. It is purulent peritonitis. And the last one that you have is stage 4, which is your fecal peritonitis. It is your fecal peritonitis. Okay. Now you tell me what stage do you have here? It is clearly mentioning that you have a patient with fecal peritonitis. Fecal peritonitis is stage 4. So answer here is going to be D for Delhi. That is going to be stage 4. Okay. No if and but. Clear cut. Right. Now, what is the most common neuroendocrine tumor of the pancreas? This we have been asking again and again. What is the most common neuroendocrine tumor of the pancreas? Is it the gastronoma? Is it the stomatostatinoma? Is it the insulinoma? Is it the VIPoma? So we all know it cannot be somatostatinoma or VIPoma. Usually the confusion is going to be gastronoma as well as insulinoma. The answer is going to be insulinoma. Now the question that they'll ask you in the context of gastrinoma is, what is the most common site for gastrinoma? The answer is going to be duodenum. See, rather than saying duodenum, you should say that it is more commonly seen in the Passaro's triangle. The Passaro's triangle is also called as the gastrinoma triangle. Now, what are the components of the gastrinoma triangle? A quick recap on that as well. Now, you take this as the representation of the liver that you have. Let's say this happens to be the esophagus. It continues into stomach. Then you have the duodenum. Then it goes across here. Okay. You have the left and the right hepatic duct, the common hepatic duct, cystic, gallbladder, and the common bile duct. This is where you have the pancreas, which is going to go across here. Okay. So usually when you talk about the duodenum also, this is the first part of the duodenum, this is the second part of the duodenum, this is the third part of the duodenum, and the fourth part of the duodenum. So 3 points that you have to mark: the junction between the cystic duct and the common hepatic duct, then between the second and the third part of the duodenum, and the neck and the body of the pancreas. You join these 3 ends. This is what we call it as the Passaro's triangle. Aman, absolutely continue करेंगे बेटा. BLS series is going to be continued till the entire Balian love is going to be completed. लेकिन पहले जो हमारा नीट पीजी का एग्जाम है, जो बच्चा है उनके लिए we are doing the series of. So hence थोड़ा सा ब्रेक चल रहा है. Once we are done with all these exam prep, we'll go back to our Balian love. ठीक है? So here what do you have? The first point that you have, this is point number 1, this is point number 2, this is point number 3. Point number 1 is going to be the junction between the cystic duct and the common hepatic duct. The point number 2 is going to be between the second and the third part of the duodenum. The third point is between the neck and the head of the pancreas. Sorry, the neck and the body of the pancreas. The neck and the body of the pancreas. Okay. So this is going to be with respect to that of the Passaro's triangle. Okay. Insulinoma mein, I know everybody knows that there is a triad which is called as the Whipple's triad. Right. So here in Whipple's triad, the patient will have severe hypoglycemia. When you measure the glucose levels is going to be less than 40, and immediate reversal of symptoms on administering glucose is what you see in insulinoma. Everybody knows it. Enucleation is the treatment of choice. Intraoperative ultrasound is the investigation of choice to localize the insulinoma. All these are previous exam questions. Do not goof up on that. So what do you have? Next one, I have a 35-year-old man presented with recurrent episodes of fever with chills. MRCP images shown below. What is the most likely diagnosis? Now, in this question, when you look at this, the entire component, you see the MRCP, the bile ducts are dilated, the lower ducts are also dilated across here. This is a primary sclerosing cholangitis, this is a Carlis disease, oriental cholangitis, or primary biliary carcinoma. What do you think the answer is? Quick feedback. I'm waiting for your feedback. This is your exam question. Quick feedback. In primary sclerosing cholangitis, there are going to be multiple irregularities that you will see, which you can see very well evidently here. Carlis disease, only intrahepatic bile duct is going to be involved. In oriental cholangitis, only extrahepatic. In primary biliary carcinoma, you will see the hilar tumor is present. Rest of the ducts will remain same. They will not be in this context. You see, there are a lot of irregularities is there, and that is going to be a primary sclerosing cholangitis. Okay. Okay, what do you have here? Right. What does the given barium swallow show in the image? See, barium swallows cannot show the components here, but then in certain things you should be very, very, very careful. Okay. What does it show? Quick feedback. So it is probably in the cervical region that you are going to see. And you see this is the barium swallow that you have, and this is the notch that you can see across here. Okay. Now, what do you think is your answer? Quick feedback. Esophageal cancers, no. The esophageal cancers will be more towards the middle part of the esophagus. They'll be irregular. See, this is a very smooth border. If you look at the entire filling defect, it's a very smooth filling. This you cannot have in cancers. If at all this smooth filling is there, that can be there in leiomyoma of the esophagus. This cannot be the answer. Carotid body tumor is at the carotid bifurcation, which has no relation with the esophagus. This is also gone. Aortic aneurysms, when they compress, aortic aneurysms, especially the descending thoracic aortic aneurysms, can compress the esophagus, but there will be a uniform compression, not at one particular point. So it cannot be aortic aneurysm. It is more likely to be a pharyngeal pouch. Okay. So, A patient was found to have a mass arising from the antrum of the stomach, which involves the head of the pancreas and metastasized to right lobe of the liver. How will you manage this patient? Okay. So it is basically a periampullary carcinoma. Right? In periampullary carcinoma, the answer to the question, now he is already having a liver metastasis. Right? In a liver mets, patient is having these cancer arising from the antrum of the stomach, involves the head of the pancreas. Okay. Metastasized to right lobe of the liver. Now it is becoming a metastatic tumor. In a metastatic tumor, only doing a gastrectomy is not an option. Gastrectomy with right hepatectomy is again not an option because pancreatic head is also involved. Now, if you want to do a Whipple's procedure, in the Whipple's procedure, you're not addressing the liver tumor. So, hence, this is also not possible. So, palliative gastrojejunostomy followed by chemotherapy, because here I don't want, see, here the metastasis is there. Because it is metastasizing to liver, I cannot do Whipple's. If there was no metastasis to liver, periampullary carcinoma, Whipple's is the surgery of choice. Like, if it is going to metastasis, then you do what? Triple bypass. That's what I've spoken about it. No. So you do a gastrojejunostomy, you do a jejunojejunostomy, you can do a hepatojejunostomy, that is the triple bypass. But here the bile duct is not getting obstructed. So here you can do a palliative GJ with chemotherapy. Absolutely correct. Clear? Now, in the other context, when you talk about it, the next question that you have in hand is which of the following is the most common complication following ligation of the first vessel during abdominoperineal resection of rectal cancers? Take this question, guys. I'll just take 2 minutes break. Hold on for a second. I'm getting a phone call from the hospital. Take a 2 minutes break. Solve this question. I'll be back in a bit. Alright guys, let's continue. Back on. Okay, chalo. Let's take from where we left out. Let's move on. Can we move on? Chalo. Let's go. Now, this is an interesting question. Okay. So, which of the following is the most common complication following the ligation of the first vessel during an abdominal perineal resection for rectal cancer? So, usually when you're ligating the first vessel for the abdominal perineal resection, you're going to take the rectal stump out. Now, in order to take the rectal stump out, you're going to ligate a superior rectal artery, which is going to originate from inferior mesenteric artery. Okay. So, basically, when you're ligating the inferior mesenteric artery, now the superior hypogastric plexus, now this is going to carry the sympathetic fibers. Are closer to the inferior mesenteric artery. When you ligate this, there is a good chance that you can damage this also. That is a superior hypogastric plexus, right? Now, injury to this superior hypogastric plexus in males, it will result in retrograde ejaculation. And also bladder dysfunction. Okay. So in that way, I can say it is a sympathetic gone. So when you take out the option parasympathetic cannot be the answer, this goes away. I'll say a sympathetic, it is going to result in retrograde ejaculation. So bladder dysfunction is okay. It causes bladder dysfunction. It has sympathetic fibers gone. It does not cause impotency. It causes retrograde ejaculation. So sympathetic fibers, retrograde ejaculation, bladder dysfunction. Here it is going to be C. It does not cause impotency. So answer here is going to be C for Calcutta. Is that clear? Okay. Chalo. Going on to the next one. I have a 54-year-old female presents with the abdominal pain, bilious vomiting. She had a history of abdominal hysterectomy 2 years back. On examination, abdomen auscultation revealed a high-pitched bowel sounds. Investigation shows air within the biliary tree. What is the most likely diagnosis? Okay. Now, when a patient is having abdominal pain with bilious vomiting, this is like the features of bowel obstruction, especially the small intestine, because there is no mention of abdominal distension. So D, she has already underwent abdominal hysterectomy 2 years back. On examination, abdominal auscultation revealed a high-pitched bowel sounds, obviously because of the bowel obstruction. Pneumobilia, that is air in the biliary tree. And if I add ectopic gallstones, this is what we call it as Wriggler's triad. Now, the Wriggler's triad has been our previous exam question as well. Okay. Now, in a Wriggler's triad, what is the most likely diagnosis? The answer is going to be gallstone ileus. See, if you talk about adhesive intestinal obstruction, it will not have pneumobilia. Intestinal obstruction can be secondary to this. Abdominal hysterectomy is the confusing term, which is pointing towards that probably you're talking about intestinal obstruction due to adhesions. I can take that point into consideration, but you will not have pneumobilia. So this cannot be the answer. Ischemic enterocolitis, for that you need to have any ischemic injury, and enterocolitis will have, due to ischemia, there is severe abdominal pain and there will be pain out of proportion to the abdominal signs, and that is not been associated here. In diverticulitis, there is no pneumobilia. Okay. Here also you will not have pneumobilia. The only condition which is associated with pneumobilia is gallstone ileus. Another condition that you can have in the same context is what we call it as the Barrett syndrome. What is Barrett syndrome? It is gallstone-induced gastric outlet obstruction. As simple as that. Okay. So, in either conditions, the gallstone ileus is basically because of bilioenteric fistula. The most common site for fistula is between the gallbladder and the duodenum. That is cholecystoduodenal fistula. Okay. So, don't miss on that as well. Now, I have a 20-year-old female consumed cleaning products of 90% sodium hydroxide She is having a complete dysphagia. What is the best step in the management? So when we talk about the caustic injuries, in the caustic injuries, we have the injury to the stomach as well as to the esophagus. So here I cannot do a bypass with the esophagus. This is not possible. Stenting is not done until unless there is stricture present. Feeding gymnostom is important because this is what I want my patient to receive. Gastrogymnostom, because again there will be injury in the stomach, ingesting the caustic injuries. I will not take that into consideration. So answer here is going to be C for Calcutta. No point in bothering about it. Yeah. Cool. Going into the next one. A 5-year-old child admitted to the hospital for prolapsing rectal mass, painless rectal bleeding. HP reveals enlarged and inflamed glands filled with mucin. What is the most likely diagnosis? So when you have an enlarged inflamed glands filled with mucin, they are basically indicating polyps, and those polyps, absolutely correct, Abhijit. These are the histological findings of the hamartomas polyps. These are basically an hamartomas polyps. Do not call it as hamartomas, right? They are hamartomas polyps. ठीक है? देखो कोरिस्टोमा और hamartoma में फर्क है ना, right? So these are basically hamartomas polyps. ठीक है? चलो. Now going on to the next question. A patient presents with sudden onset of hematomesis, has been taking aspirin for arthritis, drinks alcohol occasionally, gives a history of occasional abdominal pain. On investigation, there is no abdominal mass or tenderness. What is the likely diagnosis? So, patient is having, okay, hematomesis ka episode hai. He takes aspirin but drinks alcohol also. Aspirin will cause erosive gastritis. ठीक है? Now, drinks alcohol occasionally. ठीक है? On history of occasional abdominal pain also. See, Mallory, we stare. It is because of recurrent episodes of vomiting. Now, because there is no history of recurrent episodes of vomiting. Now, this recurrent episodes of vomiting can be because of, it can be secondary to what? It can be secondary to, you can say, acute alcoholic. It can be because of, hyperemesis gravidarum. It can be secondary to cisplatin-induced vomiting, anything. So, here recurrent vomiting, they have not spoken about, it cannot be Mallory-Wistar. Esophagitis. Esophagitis will present to you with pain. It is not going to pain on swallowing, but it will not have hematomesis. Okay. Peptic ulcers, yes. How can have peptic ulcers? Whenever you're using an NSAIDs, these NSAIDs are basically cyclooxygenase inhibitors. Cyclooxygenase inhibitor decreases the prostaglandin. Decrease the prostaglandin will cause decrease in mucus secretion. And whenever the mucus secretion decreases, the concentration of hydrochloric acid inside the body will increase. Now, this will result in erosion resulting in peptic ulcer disease. And peptic ulcer disease indicates that there is going to be pain, there is going to be bleeding that is causing hematomesis. So, the best answer to this question is going to be NSAID-induced gastric ulcers. That is going to be C for Calcutta. Esophageal varices will present to you with bleeding without pain. They present to you with massive hematomesis without pain. It is massive hematomesis without pain. Absolutely correct, DeBakey. That is type 5. According to modified Johnson's classification, this will be called as type 5 ulcer. Okay? So, going to the next one, I have a patient presented with the features of chronic pancreatitis. Then there is recurrent attacks with recurrent attacks. Okay? And a 10 millimeter dilated of pancreatic duct with intraductal calculus present. Which of the following is the surgery of choice? Now we say, if the major pancreatic duct diameter is less than 7 millimeters, then I would do a ERCP with stenting. If it is more than 7 millimeters, then you have to do surgery. Correct? Now, the surgery depends where exactly are you concentrating. Is it on the head or is it on the tail? Is it on the head of the pancreas? Is it on the tail, body or the tail of the pancreas basically? Is it on the body or the tail of the pancreas? Sorry. If it is going to be body or tail, you can do Duval procedure and Pustows. Head of the pancreas, we do Beggars, and then you have Frays. Okay. Okay. 10 millimeter stone is there, duct is dilated, sorry. So you will not do an ERCP and sphincterotomy. Okay. Now, pancreatoduodenectomy is Whipple's procedure. So why would I do Whipple's? Pancreatoduodenectomy is called as Whipple's. So there is no role of Whipple surgery. So this is also gone. Now, longitudinal pancreatitis Pustows is what we called as LPJ. That can be one option that you have. Coring of the pancreatic head. The coring of the pancreatic head is what we call it as Frey's surgery. So you have Frey's here and then you have Pustows here. So there are two surgeries which you can actually do for a chronic pancreatitis. Now it says recurrent attacks, dilated pancreatic duct with intraductal calculi present, which are the following. So the stone is present throughout the duct. If the stones are present throughout the duct, the longitudinal pancreatitis is a better one, which is compared. Mishra, absolutely correct, beta, spot on. If the disease is concentrated only in the head, then you go with Beggars and Frays. Okay? So when you talk about head coring, it is only going to be Frays. Clear? So, going on to the next question. A patient presented with right hypochondriac pain, episodes of diarrhea 1 week prior. Okay? CT scan of the abdomen revealed a liver abscess around 25 cc. What is the next step in the management? So history of diarrhea is there and then the patient developed liver abscess. This is a classical sequence of amoebic liver abscess. The amoebic liver abscess. Because it initially causes colitis, colitis causes diarrhea and then it goes and causes amoebic liver abscess. Now for amoebic liver abscess, the management is going to be high dose metronidazole. The management is going to be high dose metronidazole. When I say high dose, it is going to be 700 to 1000 milligrams for 3 times a day for 14 days. Okay. So pair is for hydrated cyst. So this is not a hydrated cyst, so this is wrong. Surgery is done for two conditions. One is going to be if the patient is having hydrated cyst or pyogenic liver abscess. Okay. Here medical therapy is what you're doing, high dose metronidazole. If it fails, then you go with aspiration. Percutaneous drainage is only done for your pyogenic liver abscess. Okay. So answer here is going to be C for Calcutta. It is going to be medical therapy. Got it? Chalo. Going to the next question. What do you have? A patient who is a known case of alcohol dependence syndrome presents sudden unintentional weight loss. What is the most likely diagnosis? So you have given the options which you have. The ALP is there, bilirubin is normal, AST-ALT ratio is there, alpha fetoprotein level which is there, which is going to be increased. AFP is increased. Okay? When the alpha fetoprotein is elevated, in which condition? So known alcoholic, sudden weight loss, should be malignancy. Okay? It is not adenoma, right? Bilirubin is normal, it cannot be cholangiocarcinoma. It looks like hepatocellular cancer because in cholangiocarcinomas, the bilirubin level will be raised. Right. The next question that you have, a baby playing with unsupervised is brought to the complaints of difficulty in swallowing for the last few hours. X-ray is given. What is the diagnosis? Okay. Now you can see in face. So in an AP view, if you are able to see the entire face of the coin, this is going to be in esophagus. Okay. This is going to be in esophagus, right? If you see laterally in face, then it is going to be in trachea. So here it is going to be in face which is present in the esophagus. ठीक है? अगर AP view में पूरा coin दिख रहा है, it is going to be esophagus. अगर lateral view में पूरा coin दिख रहा है, it is going to be trachea. As simple as that. इससे बड़ा कोई component है ही नहीं. ठीक है? चलो. Next question. 25-year-old patient brought to you with abdominal pain, fever for 3 days, duration, chest X-ray, and erect position given below. What is the most likely diagnosis? I want you to look at this particular side. This is free gas under right hemidiaphragm. It is hollow viscous perforation. So the answer to this question will be not gastric volvulus. It is hollow viscous perforation, not abscess, not empyema thoracis. It is going to be hollow viscous perforation. Free gas under diaphragm. Okay. Okay. Next one. A patient found to have a mass arising from the antrum of the stomach involving the head of the pancreas, metastasis, lever lobe. How will you manage? I think we have already spoken about this. Is palliative gastrojejunostomy followed by chemotherapy that is to be required. Next question, it is going to be a patient presented with fever, abdominal pain, jaundice. Investigation is given below. What is the following statement true regarding this condition? You can see this free floating membrane with the cystic lesion in the liver. This is hydrated cyst. So the first thing that you see here is the diagnosis of the hydrated cyst. Now, surgery is mandate. Which of the following conditions is true? Fine needle aspiration cytosis diagnostic. No. Diagnostic, this is wrong. Right? ELISA is diagnostic. Okay. Angioembolization is not the treatment of choice. PAIR is the treatment of choice. Echinococcus species is involved in the etiology. Yes, Echinococcus granulosus. Okay, is the one which is actually causing the hydrated cyst. Right? Now, surgery is mandatory. You can do PAIR, that is percutaneous aspiration and installation of scolicide agent. Surgery is not always mandatory. Last one is your capitonage when the PAIR fails. So, answer here is going to be D for Delhi. Clear? Clear? Chalo. Next one that you have, what do you have? A 45-year-old man complains with the recurrent discharge and pain due to lesion around the anus for 2 years. Okay. What is the likely diagnosis? It is around the anus. So the answer has to be fistula. You know, pilonodal sinus is going to be in the gluteal cleft. And there has to be hair around it. So hirsutes में common होता है, gluteal cleft के ऊपर मिलेगा. Carbuncle will be multiple sinus. There will be multiple sinus. Boil will have short history. It won't be for 2 years. So answer here is going to be fistula in ano. Bottom. I think this is a repeat one. I have a patient with acute onset severe abdominal pain, hemodynamically stable chest exertion. What is the next step in the management? It's a hollow. Diagnosis here is going to be your hollow viscous perforation. For all patients of hollow viscous perforation, even if the patient is stable or unstable, for all of them, it has to be an emergency laparotomy. There is non-negotiable. There is no component or no question asked. Okay? Take second, something is blocking my view here. Okay. Well, see, there has been question, what is the investigation of choice for fistula? In, it is MR fistulogram. Okay. What is the best? It is an endoanal ultrasound. Investigation of choice. Investigation of choice is your MR fistulogram. Best is going to be an endoanal ultrasound. It's an endoanal ultrasound. Okay? Do not forget about it. Okay, next question. A patient diagnosed with GERD, okay, no improvement on long-term medical, underwent surgical treatment of GERD, identify the procedure. Now you can see it is a complete wrap. Okay? Now you can see the wrap that is occurring here is started from the posterior surface, come anteriorly and then complete wrap. It is a 360 degrees posterior complete fundoplication. And this is what we commonly called as the Nissen's fundoplication. So the answer here is going to be D for Delhi. Okay? Top it is going to be 270 degrees posterior. So it is partial. Door is, again, it is going to be an anterior partial. It is an anterior partial fundoplication. Can anyone tell me what is Watson's fundoplication? What is Watson's fundoplication? What is in Watson's fundoplication? Quick feedback. What is Watson's fundoplication? Watson's is what? It is also anterior, right? So I don't want to talk about degrees, but it is 180 degrees anterior. maximum if they want to, confuse in your exam. Nothing more than that. Okay, what do you have? Identify the following. What do you think it is? Is it an fluoroscopy? Is it an X-ray alkali ingestion? Is it going to be a barium swallow? Is it going to be an X-ray of an acid ingestion? What is this? Quick feedback. Let's see how many of you get this right. Quick feedback. Absolutely correct. It's a fluoroscopic follow. Okay. It's a fluoroscopic follow. You can see a complete passage. Okay. We have a CT scan of the patient with the hydrates is shown below. What type of hydrates according to the Gerbe's classification? I mean, they have been asking you again and again. Gerbe's classification is important. So in type 1 Gerbe's, it is a simple cyst which is filled with fluid. In type 2, you have a free floating membrane and the fluid is filled within it. It is called as the water lily type, or also called as the water snake type. In type 3, you will see that is multiple septas are formed. They are multi-septate, and this multi-septate is honeycomb. This multi-septate variety is what we call it as the honeycomb sign. Then you have type 4, you have where the central calcification is there and peripheral septa filled with fluid. This is what we call it as complex heterogeneous. And last one that you have is a calcified cyst. The last one that you have is a calcified cyst. So when you look at the image, I mean, can't miss out, right? The answer here is going to be type 3. It is going to be type 3 with respect to Gerbe's classification. Identify the image. You can see the image. You can see the anterior abdominal wall is opened. It is having an exposure. See, omphalocele and gastroenteritis cannot be the answer. Omphalocele will have a membrane. Gastroenteritis will be bowel exposed. Ileal diverticulum cannot be seen. It is the extrophy of the bladder where the anterior abdominal wall defect is there. Answer is going to be B for Bombay. Okay, can you see what is the condition seen here? You can see an endoluminal imaging is there and you see all these big chunky dilatations. It is not an ulcer. It is not a candidiasis. It is not a Barrett's esophagus. These are these big esophageal varices. These are your esophageal varices. It's your esophageal varices. Achha, what is the most common presentation of bleeding esophageal varices? Quick feedback. Achha, for bleeding esophageal varices, the most common cause is going to be your portal hypertension. The most common presentation of portal hypertension is also bleeding esophageal varices. Okay. Achha, can anyone tell me how much is the normal portal pressure? How much is going to be your normal portal pressure? Normal portal pressure is going to be 1 to 5 millimeters of mercury. When will bleeding occur in portal hypertension? When it is more than 10 millimeters of mercury. When would the patient have, bleeding will occur when it is more than 12. So to call it as the portal hypertension, it has to be more than 10. To call the patient is having portal hypertension. To call it as portal hypertension, it should be more than 10 millimeters of mercury. The bleeding in portal hypertension has to occur when it is more than 12 millimeters of mercury, and the risk for mortality, that is the death, increases if it is more than 14 millimeters of mercury. Okay, don't forget about it. Correct, Abhijit. Terlipressin octreotide can be given This is a whole algorithm, no, where you go and look across it. Identify the image for pseudomembranous colitis. You need to have this patchy appearance, and that is your image number 1. Answer is here. Answer option C for Calcutta. Okay, pseudomembranous colitis, right? These are erosions are present here, so it could be because of the colitis that you can see across here. These are usually the picture that you will see in ulcerative colitis, where you have multiple erosions are present, and this is like a non-relevant image. Okay, not important about it. A male presented with discharge as shown in the image. What is the likely diagnosis? Now you can see there is fissures which are present and a sentinel tag is present. So this is fissure in ano. It is not fistula in ano. Fissure is a longitudinal ulceration that you can pressure, and then use this tag, skin tag that is present is called a sentinel pile, which is usually seen across here. Okay. Okay, what do you have? A baby was brought to you with the complaints of intermittent fluctuant discharge from the umbilicus. What is the likely diagnosis? You can see here. Okay, this is a very clear-cut image you can see, which has been pointing here also, and they'll be pointing in this context also. Okay, what is this? Quick feedback. So this is basically a vital intestinal duct abnormality that is present. Okay, intermittent fluctuant discharge that is present in the umbilicus. It is not a polyp. Okay. Now it is not a urachal cyst because there's a discharge. Okay. What is your answer in this question? Quick feedback. Quick feedback. See, patent urachus will be associated with the, it is going to be associated with the bladder. Okay. Now here you can see it is an ileal diverticulum. Cool. So this concludes your first half of the PYQs present in the general surgery. Because ours is a much bigger topic and a bigger subject, so I don't want you to cram everything at the same time. We have finished half of the PYQs. The other half we'll do it in the another day of session where you have all these questions which are present. I think another 40-50 questions are present which are there. We'll finish in the next session. Okay. Until then, thank you so much for joining. Have fun. Take care. Go through all these questions. It's a quick recap. I try to put you on a reasoning basis. Any questions, any queries, tag me, post me, ask me the questions, and all the best for your exam. We'll do this session, the rest of off in the next coming few days, and we'll wrap this session up. Okay? Any questions, any queries, feel free to ask. Until then, thank you. Goodbye. All those guys who are wishing me birthday, thank you so much. The birthday is not today, it is tomorrow. But thank you so much, guys. See you, love you all, and do great. Thank you. Bailey in Love will restart again once the NEET PG is done. Until then, we're taking a small halt, but it will be done. All right. So, thank you so much, guys. Bye. Take care. Good night.